shall now go on to our next speaker, Dr. AVINASH BAGZAI, who is again a senior consultant at the Center for Sight group of hospitals at Indore. And he's going to be showing us this video. On to you, Dr. AVINASH.
Thank you very much, ma'am. Let me thank you personally, the AIOS, the AIC Managing Committee, to give me this opportunity to present myself in front of all of you. Anandji, can you please help me with the video? Can you please start the video?
So just give me a minute, sir.
So I'm here demonstrating an impending nucleus drop to be managed with a relatively simpler technique called as posterior optic buttonholing, commonly known as posterior optic capture. So I'm just going to demonstrate how can we manage such a case, and how can this technique help us in managing otherwise, commonly encountered PCRs as well. Yeah. So cataract surgery is one of the most commonly performed surgeries
across the world.
I guess. Okay. So cataract surgery is the most commonly performed cataract surgeries across the world. But we as cataract surgeons always fear a posterior capsular rent, which can occur in any of the simple cases to the complicated cases like posterior polar cataract. And we sometimes, face a problem managing such cases, especially with the IOL centration and the post-operative AC reaction are the commonly faced challenges by us all. So here I'm demonstrating this technique, POBH, in which the optic is buttonhole, just like a button is tucked in, into its place. So in this technique, the optic of the IOL is placed just behind the anterior capsular margins, just like the button. As you can see that the blue edges of the optic are just behind the circular anterior margins of the rhexis. So the ideal size of the rhexis should be 4.5 to 5.5 millimeter diameter, and the best advantage of this technique is that it forms a watertight diaphragm, preventing any further movement of the lens. So here in this case, this is a posterior polar cataract. Routine phacoemulsification steps are being performed with all the precautions which we normally follow in a posterior polar cataract. A central circular round rhexis is being made, and routine steps like hydrodelineation is being performed instead of the routine hydrodissection. As we proceed with the phaco, stop and chop technique, here we were making a trench, and while making a trench only, we realized that there is a sudden deepening of the anterior chamber, and the nucleus was found to be becoming unstable. It was kind of sinking down, and then we kind of rotated back it into the bag. The phaco was abandoned and the procedure was converted to an SICS, where a temporal tunnel was made, so that we be sure that we don't have to apply sutures in the end. Again, the nucleus was dialed back into the AC, and with the help of an irrigating vectis, the nucleus was taken out of the anterior chamber. And then a meticulous anterior vitrectomy was done, and the remaining cortical pieces and the cortical matter was then removed with the irrigating vectis. And after making sure that there is no more vitreous in the anterior chamber, the rent margins, the anterior capsular margins were reassessed. And you can see in this photograph that the circular anterior rhexis margins are very well made out. And we proceed with the implantation of a 3-piece IOL in the sulcus. And you'll see the very important step now. You just push one edge of the optic behind the anterior capsular margins, and then the other 180-degree opposite, you just push it slightly posteriorly behind the anterior capsular margins, giving you a very well centered IOL. And you can see the dial is very well centered. There is no post-operative reaction. And the advantages of POBH are it reduces the post-operative anterior movement of the IOL. The pressure is not raised a lot. There is lesser AC reaction post-operatively. And there is no difference in macular thickness compared to the standard in the bag IOL placement. And the other advantages are that it lowers the chances of iritis and the pupillary block syndrome. It creates a very good centration, and also it relatively stabilizes the vitreous space, so it reduces the chances of a retinal detachment as well. So the message to take is do not panic. Even if you encounter a PCR, you can convert to take from phaco to SICs or ECC if required. And the POBH offers a very good technique in all such cases to prevent post-operative complications in which you cannot place the IOL in the bag, like in traumatic cataracts with a large anterior capsular rupture or absorbed cataracts or very large PCRs which prevent in the bag IOL placement. Thank you.
Thank you very much, Dr. Avinash. Let's go on to discussing. I'm going to take this question with Dr. Ramurthy. Now, if you were to do an anterior optic capture, would you change the IOL power? If you were to place the IOL on the rexus, would you make a change in the IOL power? If it is going to be a different intraocular lens to that which was planned in biometry, would there be some changes which you incorporate? I think I would want this question to be answered for the young audience.
Oh, actually, when he was presenting, I was thinking one of the advantages of creating an optic capture is that you don't have to change the IOL power.
Yes.
And so you can go ahead and stick to the IOL power that was originally planned.
Yeah.
And when you are shifting to the sulcus, one of the dictums is that you reduce it by about 0.5 diopters. But again, it depends upon the power of the intraocular lens that you're implanting. So there is something called Uday Devgan talks about this rule of 9, where if the power of the original lens is less than 9 diopters, you don't have to make any change at all. If it is 9 to 18, you make a change of 0.5 diopters. 18 to 27, it's 1 diopter, and above 27 is 1.5 diopters. I use that. I mean, of course, very rarely this comes into play, but it does make sense because the higher powered lens, as you displace it anteriorly, the amount of reduction that is needed is likely to drop down. And a couple of comments regarding what the video that was shown, very nicely managed. One thing was that, when you have, anytime you have a vitreous loss, I think in today's world, you must use Tamslone state to make sure that complete anterior vitrectomy has been done and there are no vitreous strands in the AC. Just getting a round rexus or a round pupil is not good enough to tell you that there's no vitreous in AC. Even whenever I have had no vitrectomy has been done also, if there is a PCR, even after placement of the lens before coming out, closing the case, I just put a little bit of diluted Tamslone, and that often shows up 1 or 2 strands which can be handled right away. And that does help in better outcomes.
Identifying the vitreous.
Since we are talking about optic captures, I
and
think
one other factor I wanted to say is that, when you are doing all these maneuvers, invariably viscoelastic goes into the vitreous cavity. PH was saying in the previous instance, before creating the optic capture, is extremely important. You keep the irrigation cannula in the anterior chamber, go with your aspiration cannula behind the optic of the lens, and then remove all the viscoelastic that invariably seeps in there, and then just nudge the optic of the lens with your aspiration cannula itself, which will create a nice optic capture if the rexus of the right size. Otherwise, this will lead on to raised intraocular pressure, inflammation, which will take a long time to clear up.
Sir, I remember some video about Dr. Osher. He had shown something about how vitreous is actually helping us with the cataracts. Could you elaborate on that with the slow-mo, with relation to the slow-mo phaco?
I'm not able to catch your question, Abhijit.
Can you explain yourself, Abhijit?
Can you hear me?
Yes.
Yeah, I can hear you.
What are you? Can you convey?
So there was this video which I remember of Dr. Osher, how he showed that the vitreous actually doesn't pull it down unless the vacuum and the settings are really high.
Yeah.
Mm-hmm.
I think he means to say that the vitreous, an intact vitreous face, actually helps in supporting the nucleus and preventing it from falling out.
It does.
It does.
So could you elaborate on that?
Another thing which all of us are doing, but if there is a nucleus dropping, it's an anterior vitreous phase. Now, if in those setups where you have a retina setup, good setup there, would you like to go in with your vectors and get the nucleus even if it's in the anterior vitreous plane, or would you like your retina consultant to take on from there? I want the thought of the experts.
So I was talking about the slow-mo phaco here, because instead of going in with the vectors, he could have actually converted to a slow-mo phaco here and finished the cataract with the phacoemulsification as well.
But then you're pulling at the vitreous base, you know, from so many places. And
No,
the
the
nucleus was
vitreous
already-
base does not get pulled at that stage. The moment you realize it and you're converting it to a slow-mo, the vitreous even doesn't come ahead. It doesn't herniate.
I
So
think
then you should bring the
can,
nucleus forward and do a supracapsular phaco maybe, but again, those pieces and you should keep injecting viscoelastic all the time, viscode, so that the vitreous continues to be behind.
I agree.
Take on this, Abhijit, would be that if the anterior hyaloid face is intact and there's no vitreous disturbance, then maybe you can use a dispersive viscoelastic to tamponade the vitreous, even put in an intraocular lens either in the sulcus or in the back to hold back the vitreous, and whatever nucleus fragments, cortex is there, then you can go ahead and handle it. But if vitreous has already come into the anterior chamber, got mixed up with the lens material, I think any maneuver that you do without handling the vitreous is going to create a significant traction on the vitreous base and lead to problems.
Yeah,
Definitely.
While we are on optic capture, there's one other information, like supposing a person has placed a lens, does a reverse optic capture as a last minute bailout situation. I would want expert panel to comment that what problem can happen post-operatively, the residual myopia which can happen, and is that something we have to be left to handle with because you have just managed to somehow keep the lens captured? I suppose you can't do anything because the lens is already in the bag, right?
Most often when you're creating a reverse optic capture, you're least bothered about a 0.5 diopters of power being there.
Yeah. It is just that I wanted that point we brought out.
Actually.
So Anaga, anything to ask? Shall we go on?